This episode of DocTalk is brought to you by FirstBank. We're not just your neighborhood bank, we're your neighbors. Our local team lives up to the name, putting our customers and community first. To experience FirstBank difference, stop by any of our 13 Knoxville area locations or visit firstbankonline.com. FirstBank, member FDIC.
Hello, I'm Dr. Rob Page and welcome to DocTalk. DocTalk is a podcast that's produced by the Knoxville Academy of Medicine, which features its physician members giving information to patients, which is helpful and sometimes essential in making good healthcare decisions. I feel very pleasured to have here today. With me today is Dr. Greg Curtin. Curtin, I'm sorry.
That's fine.
I screwed it up the first time. I knew I was going to screw it up again. Dr. Greg Curtin, who is with Abercrombie Radiology. And we were just discussing, we've both been here for about the same period of time, about 20 years. So, and our first topic of the day, which we'd like to discuss, is emergency radiology. Can you describe to me in sort of a general sense, now most of us patients have been to emergency rooms. We understand, that there are occasionally imaging studies involved. What is involved in a general sense in emergency radiology?
Well, some components are just the same as they were 30, 40 years ago. You fall down, you injure your knee, and you get a knee x-ray. And that's still done today. So plain x-rays, the things we're used to, the chest x-rays, plain images, ankle x-rays, are very much a major component of emergency radiology. More and more, though, we're doing cross-sectional imaging. Emergency departments have, over the last 20 to 30 years, with the improvement in technology and especially CT and ultrasound, are using CAT scans now to do a lot of the diagnostic work. Say if you go in for abdominal pain and there's a concern for appendicitis or diverticulitis, a lot of different types of things. Whereas in the old days, you get some X-rays and maybe they would call a surgeon in, and maybe they're, who knows, hours. Nowadays, we typically, the emergency room doctors will order a CAT scan if they're unsure if the patient is sick enough. And it's a really fantastic modality in diagnosing things that are what we call an acute abdomen, where appendicitis, kidney stones where they've blocked the ureter. We see a lot of diverticulitis, where patients with colonic diverticula, they become inflamed and infected and can lead to serious consequences. The other major modality we're using in emergency medicine is ultrasound. A patient goes in with a swollen leg. He's just driven from Memphis back to Knoxville, and there's concern of a blood clot in the leg, or what we call a deep venous thrombosis, or DVT. Ultrasound is a really sensitive and excellent and quick modality in diagnosing blood clots in the leg that could potentially break loose and go to the lungs and cause a pulmonary embolus. So the other thing we use a lot is belly pain for suspected gallbladder disease. Ultrasound is an excellent modality to look at the gallbladder, to evaluate it, looking for gallstones, inflammation of the gallbladder itself, and for obstructed bile ducts.
Now, my question would be, if we have better modalities that can be more sensitive, like a CT scan or an ultrasound, why is there still a lot of draw to doing plain X-rays?
Well, the plain X-rays serve a great purpose. If a patient comes in with a fever, cough, elevated white blood count, it's very suspicious for pneumonia. A simple chest X-ray will usually make that diagnosis. You don't need to get a CAT scan for something like that. The CAT scan is also, it's a more expensive test. There's a lot more radiation involved. The radiation levels are still well with what we consider acceptable, but a chest X-ray is very simple. In that kind of scenario, is a very effective way to diagnose a pneumonia. A sprained ankle, an injury to an extremity, a plain X-ray is excellent at picking up fractures. It's still, the resolution is excellent, and we don't have to run the films anymore like we did in the days and wait for them to process. They're actually taken with a digital technique, and the images are available to us, within minutes. So the plain X-rays still have a very important role in emergency radiology.
Now you mentioned something about radiation. What's the difference in the radiation levels between what you would get just from a plain X-ray, which is a great screening tool, as opposed to a CT scan?
Well, you know, a plain X-ray, I try to liken it to how much radiation we get in our ordinary lives, like flying on an airplane. Years ago, I kind of looked at these numbers, and I know like a chest X-ray, a typical PA lateral 2-view chest X-ray, would be the equivalent of flying to, say, Denver, Colorado, and back at 30,000 feet altitude. So we get more radiation at higher altitudes. People who live in Denver get more radiation than we do here, at 1,000 feet. The CT, it varies a lot based on what the type of exam you're getting.
Gotcha.
But it is significantly more. But again, the technology has improved dramatically, where we're using as little radiation as possible, and also using as few sequences or as few images as possible. So it's called a process or a policy called ALARA, as low as reasonably achievable with all radiation. So I have no, I think if you're getting a CT of your abdomen and pelvis every month, then you could potentially risk developing cancer down the road. But still, the levels for a patient going into the emergency room to get diagnosed for, say, a kidney stone, for a CT, it's very low. And we get a lot of radiation just from the ground, from radon, from the sun, from the cosmos, and that's, when you look at the overall numbers for what the average American is exposed to radiation-wise, background radiation is much more than medical imaging.
Yeah, I was going to say, interesting that one of the things that I noticed when I bought a new house was they do radon checks now, so which is something that I was completely unfamiliar with. But and you mentioned that the equipment's not only the CT scan has not only become better in the fact that it exposes you to less radiation than it used to, but also are the scans a lot quicker now, and they're more easily used for an emergency situation?
That's a great question. The answer is unequivocally yes. When I started in radiology as a first-year resident in 1990, we had what were called single slice CT scans. It would take, typically, most of the exams we did were head CTs. The chest and abdomens were typically done for cancer staging. They took a long time. An abdomen pelvis CT would take, between the scanning time and the reprocessing of the images, would be on the order of 40 minutes or so. So it would take, you couldn't just, run patients through it in an emergency type setting. In the late 90s, slip ring technology came about, where instead of doing a slice, move the patient, a slice, move the patient, it was more of a spiral type process, where the table would move while the CT was running continuously, and the processing times have become much quicker. A scan time now for someone with reasonably healthy lungs, we can do a chest CT to rule out an aortic dissection, a pulmonary embolus, in a single breath hold, which is remarkable. So it takes a few minutes to set up the patient. If they need an IV, hopefully they have one, but it takes a few minutes to get an IV in. A lot of our studies are done without IVs, so they can just position the patient, getting some scouts, and then imaging. Just the imaging part really takes under a minute in some cases, unless you're going back and doing some delayed studies.
Wow. Now we've talked about plain chest X-rays. We've talked about just plain X-ray. We've talked about CT scan. We've talked about ultrasound. And one of the technologies, one of the things that I always have difficulty in is that, why is there not more use of an MRI in an emergency situation? How is an MRI better or different than a CT scan or getting an ultrasound?
The MR, it's a fantastic technology. It is used, sometimes in the emergency setting, but the images, the processing in imaging takes typically a long time compared with the CT. It's also their availability. There are just not enough MR techs that could cover a hospital, 24/7. So the big centers do have them, but we use MR a lot for musculoskeletal injury imaging, for a torn meniscus or an ACL tear in the knee. And typically those things aren't imaged emergently. That's, someone comes in and they've twisted their knee and they've got a joint effusion. The emergency doctor figures they've probably got torn a meniscus or done some sort of derangement, but that doesn't need to be imaged right away. The one time where MR's real advantage is it's really good at picking up early strokes in the very acute setting. Typically a CAT scan in the head, right, within the first few hours will be negative. Will show nothing real unless there's a bleed. Whereas the MR does tend to pick up ischemia or infarction earlier. It's just that again, it's hard to get 24/7 coverage for that type of thing. And typically, most treatment these days is if the patient has a suspected stroke, they want to see a normal head CT because then they can treat them with the thrombolytic agents, the blood thinners. And you really don't, you can get an MRI later to confirm what you were suspecting, but in a suspected stroke, a normal head CT is a good thing because it means you don't have a bleed and they can go ahead and start treating you for it.
Right. Well, you mentioned some acute settings in which these are very helpful, and you talked about strokes, you talked about musculoskeletal injuries like broken bones or torn ligaments. You also talked about using plain x-rays and things like if you have a cough or a fever or something and suspected pneumonia. What about in a situation, you talked about aortic dissection, but what about someone who enters the emergency room with chest pain? And the suspicion is, well, could be, cardiac related, not cardiac related. In what sort of scenario is emergency radiology good for analyzing that situation?
Well, there are, again, we see chest pain a lot. That's one of the major admissions diagnoses in the emergency room. And the question is, we need to determine, or the ER physicians need to determine, is this cardiac or non-cardiac? Is it a coronary artery thrombosis or obstruction that's causing the chest pain, or is it something else? Typically, if they really think it's cardiac, they're going to go ahead and consult with cardiology, do an EKG, they'll do a chest x-ray to make sure there's not a congestive heart failure. If they feel like it's not coronary artery, then they would typically get a CAT scan or what's called a CT angiogram of the chest, where we look at the aorta to make sure the aorta is not dilated or that there's not a tear in the lining of it, what's called a dissection, or also to rule out what's called a pulmonary embolus, or a blood clot coming from somewhere, the legs typically breaking loose and getting into the pulmonary arteries and blocking blood flow to the lungs. So CTA is used a lot in that because back in the day, it was hard to make the diagnosis of pulmonary embolus. There were nuclear medicine scans that were pretty good, but again, the availability was pretty limited, especially after hours. And a lot of them were sort of indeterminate. They weren't really helpful. A good CTA will pick up even the smallest pulmonary emboli, and that will definitely change the treatment for the patient.
Wow, I was gonna say that's. I remember the old nuke med scans where they do like the VQ and they would look for the blank areas in the lung, and so.
Right.
I was gonna say my wife used to be a nuclear medicine tech, and so this was something.
We did them all the time. That was
yep.
Dave Rigor back in the day.
Oh
VQs. We still do them. I mean, they're patients that have poor renal function. They can't get IV dye contrast because of the potential harm to the kidneys. So VQ scans it's a very, very effective way to diagnose it, but it's just CTA is much faster and
wow.
There's much more resolution.
Well, so many wonderful developments have occurred in radiology, which make diagnosis and treatment of so many acute scenarios in the emergency room, chest pain, head injuries, soft tissue injuries, acute stomach pains. And so many advantages offered to the patient nowadays in which they don't have to necessarily go home without maybe a solid answer, or and are there any scenarios that in which you as a patient should think specifically that a doctor should be ordering these tests, or do you think these tests are usually ordered appropriately in the correct circumstances?
I think most nowadays in emergency medicine there are algorithms they use and they're pretty standard nationwide. Someone comes in with chest pain, they evaluate for coronary artery disease, and then if there are certain tests they can do, laboratory tests where if they have what's called a D-dimer elevation, then they're more concerned about a blood clot, and they will typically go ahead and order either a CTA of the chest, or sometimes if they're concerned about a clot in the leg, a venous ultrasound. So they're not just sort of flipping a coin. They're typically following the ER emergency department standards, and when they ordered those tests.
Gotcha. So they're ordered appropriately. They're very accurate. They offer so many advantages of what we used to be able to do in terms of radiation exposure and time and everything else. So, well, now, Dr. Curtin, you're with Abercrombie Radiology. Does your group cover a lot of the emergency rooms here in this area, or cover a lot of the emergency, departments of some of the hospitals?
We do. We cover the two Tenova Metro hospitals, the Turkey Creek Medical Center, North Knoxville Medical Center up on Emory Road. We also cover 3 other Tenova hospitals, one in Jefferson City, Newport, and La Follette. And we also cover a very small hospital in Oneida called Biggs Hill Fort Medical Center, which we do direct. So we, on call, it's typically very active, especially on a weekend or a night.
Especially when the moon is full.
That's true, yeah. Or sometimes after a UT victory or loss,
That's right. That's right. So, well, you're in a large practice that covers a lot of East Tennessee. Certainly covers the Knoxville area, which is where most of our viewers are probably from. If they're interested in maybe getting any more information about radiology, do you have a website or something that?
We do, yeah. They can check Abercrombie Radiology. We have a website, and it's you can just Google it up. We're on Weiss Garber Road here in Knoxville. Or if you have questions for the hospital systems, Tenova, you can call. They have websites at all of their hospitals, and can contact them and talk to someone in the radiology department. They'd be glad to sort of fill you in on what to expect, or answer your questions, what's available.
Most excellent. Yeah. Well, that was an incredibly concise and well worded summary of what we can expect in the emergency room in terms of getting imaging studies done. And I'd like to thank you so much for joining me here today and discussing that.
Well, thank you. I really appreciate the opportunity, and hope you've learned something.
Excellent.
Appreciate it.
And with that, this concludes this episode of DocTalk. DocTalk is a podcast that's produced by the Knoxville Academy of Medicine and features its physician members giving information to patients, which is helpful and sometimes essential in terms of making their healthcare decisions. I'm Dr. Rob Page, and thank you so much for joining us.
This episode of DocTalk is brought to you by FirstBank. We're not just your neighborhood bank, we're your neighbors. Our local team lives up to the name, putting our customers and community first. To experience FirstBank difference, stop by any of our 13 Knoxville area locations or visit firstbankonline.com. FirstBank, member FDIC.